you. Thank you. So I usually speak loud enough that people can hear me without a microphone, but if you can't, just let me know. Also, if I start going too fast, please let me know that as well. I don't know how many of you were here when I presented a year ago. I'm going to use the summary slide from that last presentation as the launch board for what I'm going to share with you this evening. And I don't know if you remember last year that I am always required to make a disclaimer that when I speak in this topic, that even though I speak on matters of science and best medical practice, that I'm not representing my university or the Children's Hospital where I work at. Now, before we get into the conversation in greater detail, I want to at least remind everyone here, and myself included, that the whole reason that we're talking about this topic of sex-discordant gender identity or gender dysphoria is that our role as healthcare providers is to alleviate suffering. And we know that the people that have this experience, the vast majority of them have real and very significant morbidities that actually impact their quality of life and their functioning, and they're really crying out for help. And so the question I presented to you last year, and I'm going to say it again, is, what is it that they are seeking, and what are we offering, and is it truly helpful? And I always take a scientific kind of perspective in this, being trained as a physician scientist, but I want to touch on some other areas that I think are going to be relevant in a more practical level for all of you as well. So we're going to touch upon what's going on in the conversation, because it's not limited to science. It actually interweaves much with what's going on in society and the dialogue, as you all know, and the ideology being mixed in with the science. Talk a little bit about the developments in the last year in recognizing almost everything that I shared with you last year, and maybe at a deeper level. So this is the conclusion slide that I presented to you last year. And again, we can go into more details of this if you would like, but I presented all of the data about what we do and do not know about the etiology of this particular condition, and acknowledge that despite all of that evidence and hypotheses, that we really don't have a full answer. And I left you at that point in time with the understanding that this is likely a multifactorial condition with many different influences, some contributed by genetics, but the majority by environmental factors, and that there's much more that we need to learn. That this affirmation approach that is prevalent here in the United States of affirming one's gender identity if it's discordant with one's biological sex, including the use of hormonal treatments and puberty blockers in surgical treatment, is based upon ideological, or heavily influenced by ideological assumptions. And that's become even more apparent in the last year, that the scientific evidence itself is weak and it's inconclusive, and that there's a need for us to engage in fruitful dialogue to look at better ways that we may be able to help in alleviating the suffering, because many of the people that undergo this affirmation model will continue to have suffering, and the data has become even stronger as time has gone on, recognizing that these individuals often have continued suffering. Their suicide ideations and even suicide attempts do not necessarily go away, and some data actually suggests that they may actually increase. The relationship between the psychological comorbidities and the gender dysphoria. And I left you at that point in time with just saying that there's so much more need for exploring alternative approaches to this condition. So hopefully for those that were here last year, that will remind you of what we were talking about. Let me get my slides here. There we go. All right. Now, before I get into more discussion, I want to say more clearly that the whole basis of this affirmation model is based upon what you could say is a scientific premise. It's not always stated as that. But when we talk about medical interventions, we begin with a premise, and premises by their nature are not provable by experiments. What premises allow one to do is to generate hypotheses, and it's the hypotheses generated on the basis of those premises that lead to the experiments that are done to actually prove or disprove that hypothesis. And if we think about this in relation to gender dysphoria, that if you understand the affirmative approach based upon a scientific premise that there's a bodily defect present with an individual with normal psychological function, then the hypothesis that health will be restored by changing the body to align with one's gender identity actually makes sense. But we need to consider what the premise is and whether it's valid. The alternative premise is that this is a condition that's largely influenced or the result of psychological factors. And if one accepts that premise, then one's hypothesis about how to restore health is very different. We would then approach this in a way of understanding what are the psychological morbidities and contributing factors and try to fix those problems and help that individual as a result of that. Now, when we're talking about the affirmation model, the other concept that I want to reinforce for you this evening that I may not have done last year to as great of a degree is that in medicine, we often are working in areas that we don't have a complete data set. We're often at varying levels of understanding, but when we act as physicians and other healthcare providers, we need to weigh relative risks and relative benefits, okay? And so when we think about the risks, the higher the risk, the greater the evidence that we're going to demand before we actually will accept that and proceed in intervening. And so versus the risk of the illness itself, right? So we're always balancing risk and benefit. And I think when we think about the affirmative model, where we are making potentially and very likely irreversible changes to bodily function, including disrupting or preventing fertility in somebody that is at a developmental stage of their life where we can't predict where things will go in the future, I think the bar is, many would argue that the bar needs to be set much higher than where it is currently set. Now, this is a different version of what I shared last year in just outlining what is going on in therapeutic approaches. And this is a synthesis. This is actually from a systematic review. I'll be saying more about the systematic reviews that were published just last week in one of the BMJ journals, a very prestigious European journal, the Archives of Disease and Childhood. And it presents this model where it incorporates not just the medical interventions, but in the context of adolescence development in prepubertal children versus adolescents, and then does include efforts to provide psychological support to these individuals. And again, I think many of you most of you are already familiar with, when I say the affirmative model, what I'm talking about. The proposal that normally timed puberty is itself a disease and needs to be suppressed with puberty blockers, that offering hormones that are not native, or at least in levels that are not native to an individual, giving estrogen to a biological male and testosterone to a biological female, and then progressing on to later stages of intervention, including top surgeries or bilateral mastectomies in females that want to appear male, and then a smaller percentage of the physical genital surgery as well. Now, I'm going to say a little bit more about this model as it's developed, but before I do that, I want to at least state explicitly, what's going on in the conversation, especially when many of the medical organizations in the United States are making arguments that the professional organizations say. So they say that the AAP and the AMA and WPATH all say that this is the best approach to alleviate suffering is with the affirmative model. Okay? If it's not based upon data, what we're talking about is eminence-based medicine as opposed to what we really aspire to, of that of evidence-based medicine. And there's a drastic difference between, you should listen to me because I'm the self-reported expert, versus I have a body of data that says this is a good approach, and there's data to suggest that the risks are outweighed by the benefits. Now, this actual figure was taken from I think it was a liver journal, so it had nothing to do with gender dysphoria, but I think it applies to many areas of medicine. And we recognize in other areas of medicine where there's a problem, where we're relying on eminence and not evidence. Okay, so I just want to keep that in mind, because that's going to be very important as I share with you some of these latest developments. This is in one of the BMJ journal, Archives of Disease in Children articles, where they did a series of systematic reviews, and they looked at what has been developed internationally. There's been about over a dozen clinical practice guidelines that have been developed for the care of individuals with sex discordant gender identity. And I know you can't read the small type, especially if you're sitting in the back, but what I'm going to highlight to you here is that, and there's a couple of different ways that they present the data, but in the center here is WPATH, the World Professional Association for Transgender Health, that put forward their clinical practice guidelines, which they call standards of care, which by all objective definitions, they're not standards of care, they're practice guidelines. And this is talking, when they looked at the evidence, this was version 7 of their so-called standards of care. And then all of the other guidelines that have been developed related to that, and how much they relied upon that imminence category on all the connections. Many of the recommendations directly stem out of those recommendations, and then the Endocrine Society guidelines, which was one of the other pathways as well. Not only were they based on that, the people that put the guidelines together were the exact same people. Okay, and so that, again, when you look at these guidelines, there's certainly concerns that was not necessarily representative in looking at things in a more broadly representative view when people make the claim that all of the professional societies in their guidelines recommend this care. Okay, so what was done is actually to look at each of these practice guidelines and then look at the reliability of that data. And you don't, again, have to see the numbers here or even the categories of the different guidelines in place. Red are the ones that are problematic, very problematic. The orange or the yellow is intermediate, and the green ones have relatively good criteria when one systematically looks at that. And they looked at, the scope of the guidelines themselves, the actual people putting them together. Do they have maybe a bias because of the area that they work in and their goals? What rigor was used in the development of these guidelines, and you can see almost all of them had very poor rigor in putting them together. How clearly they put together, how applicable they are. Do they include recommendations that are relevant in the clinical practice area? And then were they actually reviewed in a way that was with editorial independence? And I think it doesn't take much to look at a slide like this and say, there's at least a basis to question the reliability of what is being put forward as established science and a preferred approach of what we should be doing. Now, this came out before I spoke last year, but I think it's become more apparent over time. The WPATH 2012 guidelines, SOC 7 was replaced by SOC 8, the latest of the guidelines. In the 8th version of the WPATH guidelines, known as standards of care, there are many statements that were made and many aspects of this that started to have people that wanted to support it to start questioning what was going on here. Now, they claimed that for the first time, that they had more rigor in examining the literature and doing systematic review. I will say in the area of treating adolescents, they explicitly acknowledged in the guidelines that they didn't have enough evidence to rely upon. So they basically said, we don't have the data to know what we should do, and in the very next paragraph said, this is what you should do. We know what you should do. And it is used to endorse the widespread use of the affirmation model, despite the rising skepticism within the scientific community. And I presented that last year in much more detail. And it endorses really the early medicalization as being fundamental, despite an international move away from that affirmative model. And I'm going to show you some of the developments that have happened in the last couple of months in relation to that. They had initially placed limits to the ages at which these interventions could be undertaken. And when it was finally published, they removed any age limits whatsoever. And as many believe that that was done to prevent lawsuits when people are receiving this care, and I'll say more about that in just a minute. They also had an interesting new chapter about eunuch identified individuals, meaning that somebody that desires to be a eunuch has a right to be able to be castrated. And they failed to acknowledge that the evidence there was so much low quality and confounding biases that were present in that document. And that's going to be important. Now, I don't know if anyone has kept up with the news, but very recently there have been many people that are in WPATH that have left the organization because for an organization that began probably as a truly scientific organization, the transformation to be an ideological based organization that really is getting away from scientific principles has actually gotten to the degree that many people that were wanting to be a part of that group could no longer do this. Now, the WPATH files came out from an environmental group that actually got access to internal email communications within WPATH. Now, I would say that there's many other areas of evidence, and this is not science. But I would encourage you that if you want to get some background about what is being done, you can probably find this in any organization, but the degree to which it became apparent when you read even their own internal communications about their pseudoscientific approach to medicine, where they recognize that they're doing advocacy, not science, but trying to still couch it in a way that appears to be scientific, I think is very apparent. The disregard for ethical principles and recognizing problems and acknowledging that, but then ignoring that and saying that they're going to still move forward. They acknowledge in many places in some of the excerpts of the emails about the medical harms that they were trying to dismiss or minimize in this approach. So that was just one of the things that has come out recently that I think we're going to see more about it in the year to come as more of this evidence becomes available in what's going on. Probably the single biggest development that is making its rounds in the news right now, because it was just in the last week, that in the United Kingdom they came out with their final, what's known as the CAS review. They had an interim report. Hilary Cass was directed by the National Health Service in the UK to investigate what is going on at the Tavistock Centre, which was the premier single institution that was caring for most of the individuals in that country in treating youth with gender dysphoria, recognizing that there needed to be some objective critique of what was going on. And so this was instituted, and not only did the report come out, but there was a simultaneous publication of a series of systematic reviews. Some of that data I showed you in some of the earlier slides, looking at the clinical practice guidelines, and I'll walk you through some of the key features that were made in those peer-reviewed publications published in the Archives of Disease in Children. But I'm going to step through some important points in the CAST review because I think it's very much in line with what I shared with you last year and makes it even more clear in a broader perspective that really the etiology of this condition involves a complex interplay between complex biological, psychological, and social factors. Okay, and this is what I shared with you last year. I think it was recognized that there are many things going on, and that it's because it's so intertwined with different factors that we have to be very careful about making generalized assumptions. It also recognized the conflicting views about the affirmative model, the clinical approach that was at that time being used in the UK. In contrast to what's being said here in the United States, that there's a single model that's been proven to be effective and we don't need any more discussion on this. They acknowledged in this report that there are conflicting views by scientists and clinicians and other stakeholders. They came to the conclusion that all of the guidelines that are present could not be applied in the UK because of many of the weaknesses that were there. They acknowledge that there is no reliable evidence by which one can make clinical decisions. That's a pretty big statement, okay? It reinforces this low quality of evidence that I have presented to you previously. I think the next statement here, that the strengths and weaknesses of evidence are often misrepresented and overstated, I think is also very important. And I think we need to be careful as we question the affirmative model, that we're very objective, and when we're looking at the studies that lack the rigor, that we don't go beyond what we can make conclusions for. I think it's a reminder that we need to remain objective and being able to be able to test the hypotheses that are being investigated. And this is there's certainly not a way that one can identify, so knowing that this data that I shared with you previously, that a very significant, if not majority of individuals, if they weren't affirmed in their gender identity, would have realignment of their gender identity with their biological sex. The recognition that the actual number of people that have that outcome, or the people that go ahead and have the affirmative approach that are now coming forward as desisters. We don't know exactly the magnitude of that, but there's increasing numbers of individuals, and there's no way to know a priori before you engage in the medical interventions of affirmation whether that individual, if you did not proceed in that way, would have another resolution to their difficulties. So they said that for most young people, and again, not some, but most young people, the medical pathway is not the best way to manage their gender-related distress. Again, I think that's a remarkable conclusion by a governmental body that was put together to look at this particular question. I'll say a little bit more about the Cass report because I think it's so important, but I want to go into some of those systematic reviews because I think that they're these are peer-reviewed, systematic, with some rigor, okay, so that they have a criteria for looking at the established literature and have come to remarkably the same conclusions. The first one I'm going to share with you is the Swedish systematic review. This was published in Acta Pediatrica last year. And what they did is they used what's called a PRISMA criteria, looking at a preconceived checklist of things that need to be present to be able to critically evaluate the data. And they looked at up to 10,000 papers that were scrutinized with this criteria. And they were only able to find 24 studies that met their criteria of rigor to be able to investigate. They found no randomized controlled trials in the entire set of data. And then the few longitudinal observational studies were hampered by small number sizes and high attrition rates. So the only conclusion that they could reach based upon moderate level evidence was there might be adverse effects on bone health by using puberty blockers, but they could not make any conclusions about the long-term effects of hormones on psychosocial health in that study. Now, when you look at the latest reviews that came out, the impact of social transition. This is actually prior to engaging the medical profession of assuming the identity of somebody that's discordant with one's biological sex. They concluded the evidence base for all outcomes of social transitioning in childhood and adolescence is of limited and low quality, and that really we need more research. Okay, similar to what was recommended a decade ago in the Endocrine Society guidelines, that they discourage social transition because it may profoundly alter the trajectory of what's going on. So again, this is another review independent of what I said last year that came to the exact same conclusion. The next is a systematic review of the literature on the interventions to suppress puberty. Using puberty blockers. Again, no high quality studies were identified with appropriate design so that one could assess the outcomes. There were inconsistent evidence about the effects on gender related outcomes, mental health, cognitive development, cardiometabolic risk, and fertility. Again, looking at all the data itself, one could not conclude that they are truly safe and effective as is being put forward here in the United States. And consistent, again, with the moderate quality evidence that affects not only bone density but final height. That was about the only conclusions they could make. And just to be fair about this, there's been some recent critique of the Cass report making false claims that they jettisoned all of the studies because they weren't randomized controlled trials. And if you hear somebody saying that, it is not true. because in the CAST report itself, it outlines many longitudinal studies that were done and looked at in various domains. This chart is showing you the number of studies that are of low quality, moderate, or high quality for the different questions that they're asking. And we can see that there are longitudinal studies there. It was a very rigorous approach to look at it. It was very objective, but they came up with the same conclusions. Now we can say the same thing for the cross-sex hormones, or the masculizing and feminizing hormones. Lack of high quality evidence about the effects in these individuals, inconsistent results about effects on gender dysphoria, body satisfaction, psychosocial outcomes. There's certainly the questions of fertility and growth. And again, the only thing they could say is that there was some evidence in the short run that the individuals that received these hormones felt better psychologically as far as their distress. And I shared with you last year a hypothesis that might relate to short-term effects that don't bear out long-term conclusions. Again, that if you alleviate a stress in the short run, but it's a necessary stress to progress through development, you may not be helping somebody. Similar to the last slide, I'm not going to spend much time on this, but again, it was a pretty rigorous review. So the children, these are the conclusions of the CAST study, that now in the UK, children under 18 in England are no longer being receiving the gender affirmative model of care in that country. The only exception is if one is enrolled in a scientific study. Okay, so the only way you can get these interventions is if you're involved in a study, and they've got a whole holistic model where they actually prioritize psychological interventions. All right, so and then I'm not going to spend time on this. This is an editorial by the BMJ, really stating, I think, very clearly, probably in very, I think, solid language, you know, that the offering treatments without understanding of the benefits and harms is unethical. I think it needs to be said. This is unethical practice. That all the more so when it involves things that are not trivial, that they can be major lifelong altering interventions, and that by proceeding in this manner that it's been done, it's a recipe for harm. So it really advocates that with the CAST report in the UK, when it's applied in that country, but I would say in our own country as well, that we use this not to dig in the ideological differences, but we actually come together and have that dialogue that needs to be happening and work for that. Now, let me switch from the UK to the United States and just give you an update on what's going on here. So the American Academy of Pediatrics, the AAP, which has repeatedly put forward the affirmative model as safe and effective and the preferred model, and it shouldn't be discussed anymore, had never made in their 2018 policy guideline, they never did a systematic review like the CAST report did, or like the Swedish systematic review that led to the reversal of gender-affirming care in that country as well. So they were forced to admit that they needed to do a systematic review. But in the announcement that they're going to make the review, they made this statement. It said, the policy authors and the AP leadership are confident that the principles presented in their previous policy guideline will remain in the best interest of children. That's before doing the systematic review. Okay, this is an example of saying we have the conclusion and we're going to take the systematic review, but we already know what the results are going to be. Okay, they said that explicitly. Okay, so that gives you kind of where we're at here in the United States. Many people have drawn attention to this and the problems with that. Now, with that, again, I want to leave plenty of time for questions. I'm going a little bit longer than I anticipated, but just let you know that there's been a progression in some of the legislative battles that are going on here in the United States. It began with questions of bathroom access, and then there's about 23 states in the United States now have passed laws limiting or banning gender-affirming care, mainly because the process that's going on in European countries is not happening in the United States. Within the medical profession itself, and many have taken upon themselves to believe that there needs to be a remedy to these individuals that are receiving this without the data. There's also ongoing questions about athletic competition. I think you've heard a lot about that. There are laws that are being passed to try to prevent one from doing anything but the affirmative model. So they call it conversion therapy bans. You know, I didn't here show the data of the states that are doing these various laws, and questions about insurance coverage as well. I will say a little bit more, though, of the things that have really had an impact. In addition to presenting the laws to restrict gender-affirming care, some of the states have actually extended the statute of limitations, which allows for a condition that may take a decade or more to be able to play itself out where one realizes that they weren't helped. That has led to an increasing number of malpractice lawsuits that are beginning to form right now. I'll give you an example of a couple of them. This is a map for the gender affirming bans in various states. The states in red are the ones that are banning care. The green, this was by a pro for affirmation website, so that's why the colors are as they are. This has actually led to the closure of a few and likely growing number of gender centers in the United States, including my own institution at Washington University this past year after I spoke with you last year. And this is the statement. I think it was useful to understand kind of the rationale. It said that they're no longer going to be using puberty blockers or cross-sex hormones. They're going to be referred to other services. They blamed the new legislation and the reason why they had to abandon that clinic because the legal claim that are being made prevents too much liability for them, meaning that they know they're going to be sued and they're trying to limit their losses, not acknowledging that maybe the intervention itself is not the best approach, because if one is providing the high-level quality care, this should not be a concern, right? So it's a acknowledgement of what we're saying. Now, these are some of the lawsuits, and there's a growing number of them. There's one in Nebraska. There's one in the Kaiser system. And actually, one of the lawsuits, they're suing the author of the 2018 AAP guidelines and the American Academy of Pediatrics. Okay, so we'll see a little bit where that's going. I won't say much more about that right now. I do want to get to questions, but people have asked me last year, and I've gotten this many times, all of this is helpful information, but in the world you live in, can I provide any pointers about ways to approach the conversation with your colleagues, maybe with your employer in the situation, or people that come to you seeking advice? So I want to walk you through first some practical suggestions for you. I don't think that they're going to be earth-shattering, but we don't always think about that. And I do, you know, I've learned this over many years, and we know this in other areas as well. My first suggestion for you is that when you're encountering somebody that has this experience of gender dysphoria, or a family that's struggling with this issue in your clinic or in your workplace, or even in a colleague that you're working with, is really to aim to develop relationships that are founded on love and respect. So, you know, I think that's very important to listen more than speak. And my experience is that when you enter into dialogue, if you ask somebody that's suffering from this condition to share their story, they want to do that. Okay, and I would encourage you to listen to what they say, because it's a launch pad to, one, you care about them. Okay, you want to learn their story, and you'll get a lot of information on that. And again, being more attentive. And I like to use in my dialogue with my colleagues the Socratic method. So you know, to share the data that I have in hand about the poor quality of science and the risks, you know, versus benefits often puts somebody in a defensive posture. But if you merely ask questions and allow them to come to the conclusions based on the questions, I think you're going to have much more success. It's less threatening to somebody, and I think it works very well. I also encourage you to be patient. So many times we want to be able to win the argument that's in front of us, and realize that you may only be, at best, be able to plant seeds that allow somebody to reflect further and gain more insight that over time may blossom into a change of heart. Since this is a group that we can say very clearly, I like to very much include prayer in that. I think that should not be a controversial statement, but also, you know, maintain long-term goals, okay, and in the big picture of what we're trying to do. Okay, again, we're not trying to win an argument. We're trying to allow an individual to have human flourishing in the widest, biggest context that many of us of faith can see much greater. The question comes up about use of pronouns, okay, and I'll give you my advice about how to navigate this. And people will have different answers to this question based upon the circumstances that you are faced with and what you can accept or not accept. I have found that by using a person's preferred name is not necessarily problematic because it doesn't necessarily convey a sexual identity, and there are many examples of that that we could cite where that can be used. In the area of pronouns, I have found that to be a good physician and to be a good scientist, that there's much caution that needs to be in that regard, because using different pronouns changes the way one thinks. And if one's generating a differential diagnosis and caring for a patient that has sex-based characteristics, you will not be a good healthcare provider if you lose sight of that. And so I tend to use gender neutral language or avoid using pronouns altogether in the conversation, recognizing that my colleagues that are trying to use preferred pronouns themselves will make mistakes all the time. There's a dissonance in the way the brain thinks in that regard, and so it's very hard even to do that if you wanted to. And if you're going to be able to enter into dialogue with somebody for a special purpose, to make the understanding of what you're saying or not saying very clear. People, I think, can respect that if they know where you're coming from. So in talking to parents, again, similar to the general guidance, you know, that love is both a word and an action, so that to be successful, you need to convey unconditional love. And you can't just say it, you have to behave in a way that says that. Again, listening, I think, is very important. I think it's important to acknowledge feelings and experiences so that, and again, you know, getting into a point of dialogue where one can listen to your reaction and being very honest about that. I find that when people understand where you're coming from in an area of unconditional love, they may not agree with you, but they can accept it in a way that allows dialogue to continue. And kids especially do much better when they know where the boundaries are, okay? And I think there's great examples of that that we can find in other areas. So that when they know, you know, where the limits are, they can navigate that much easier. And again, my admonition for prayer. I updated this. I shared this at the last talk, but I added a few other things. The biological integrity website, I think, is relatively new. But I think that there are more data out there that can speak to the topics that I presented briefly tonight. So with that, I'm going to stop and open this up to discussion, and hopefully we can have a good, fruitful dialogue with all of your questions. Thank you very much.
Thank you, Paul. Yeah, so please hand in your questions. Thank you. There was a really good question that was emailed in that I thought I would just read. I work as an RN in pediatric adolescent psychiatry. If a child with gender dysphoria wishes to be called a different name and pronouns, and parents are not aware or are against doing so, we're instructed to still use preferred names and pronouns with the child without parental consent, and the biological pronouns and legal names with the parents. I believe this to be dishonest and unethical. I've wondered how to best handle the situation, as I do not have the one-on-one time with the patient and parents as the therapists do to build the rapport necessary to appropriately address the topic, but also do not wish to go with the flow because socially transitioning a child increases the likelihood that they will pursue cross-sex hormone surgery.
Yeah, I think hopefully I already shared a partial answer to that question, you know, in talking about this question of pronouns, and I'm glad that I included that slide because I think that is a question that people have very frequently. There's different layers to that. You know, what is the dialogue between your colleagues? What is the dialogue with the patient itself? And what is the dialogue with the parent as well? And again, depending on where you work, you know, that if you take your guns out and say, you know, I am not crossing this line and I refuse to use pronouns, that may not be received very well across the board. But by having the understanding of what is the purpose of the communication and where are the areas where being accurate in understanding the sexual identity of that child is, and why that's useful. So I've spoken to several different psychologists that work in this area as well. Some of them have shared with me that in a therapeutic domain, that they say, I want to meet you where you're at, okay, and you know, this is how you're presenting yourself. Let me be very clear that if I'm going to engage in using your preferred pronouns, I'm not necessarily accepting that, but because of where you're at right now, in this short window of time, you know, we can do that so we can enter into dialogue. Okay, that's one solution. I've not been confronted with that. I've not had to do that myself. It does make sense. But I think that the best solution that I use is to just use gender-neutral language, so I avoid that altogether. I have to be very much aware of that, but I do find that using a preferred name acknowledges that you're going to meet them somewhere. And again, my thinking on this is that you know, that it doesn't necessarily convey a sexual identity, and it's not the same as is the social affirmation component of that to be able to enter into that dialogue. Because if you don't have the dialogue, now it depends on your situation of where you're going to have an influence, and if you're in a role that's not going to really make any difference at all in the child's life, you know, it's very different than if you're going to be in an ongoing relationship professionally. To be able to influence that child. So it's very unlikely that a brief interaction is going to change the trajectory of a child along a pathway on both directions. Okay, so if you dig your heels in and say, I'm not using preferred pronouns, it's very unlikely the child's going to change their mind on the spot because they recognize that maybe they shouldn't be doing that. They're also very unlikely to be, you know, suddenly move further down that. But I think cumulatively over time, I think it could be a problem. So I would just say that be prudent, be thoughtful. When I say set boundaries, I try to do that with myself as well, okay? And think about it ahead of time about in a thoughtful way of what I can do and what it's actually conveying for the good of that individual, okay? So it's not on an ideological pedestal. It's a very pragmatic, what is good medicine, what was sound, you know, just in reality, and how do we maintain that relationship? That's just my advice.
I think that the sort of a wrinkle of this is analogous to what's happening in the schools, where the parents who disagree are really in a disadvantaged situation, because I'm told that the teachers are told it's illegal for you to tell the parents what the child is doing. Mm-hmm. And so it would be extra difficult, I think, for somebody to be in the middle of that and then not be able to at least help the parents in some way.
Yeah, and I think that's really to understand, again, you know, one sphere of influence and where one, you know, can make a difference. So for that school setting, you know, there's an opportunity amongst the teachers to have that dialogue about where they're going to accept or not accept that, you know, versus, you know, there are laws that are being passed, you know, in different areas, and then there's certainly lots going on. It's always a bad idea to pit parents against children in any way, and I think that there's a rationale for being able to engage that in a questioning way, in a Socratic way of this, is this good for this child, to be, you know, hiding things from the parents without going at it, you know, from the what you have concluded and what you want to do. It's just, you know, having that dialogue.
Question, there seems to be a strong focus on youth when addressing gender dysphoria. What about young adults or middle-aged adults? Does gender dysphoria continue throughout adulthood? Mm-hmm.
So the question is, and most of my area as a pediatric endocrinologist is focused on this question of children, but in order to understand what's going on in children, it's been necessary to dig deeply into the adult literature, because that's where we have the long-term data. So there are differences and there are similarities. So some of the differences is that those that are now adults that presented many years ago were in a different environment. And the demographics that I shared last year, I think, still hold true, that prior to our current situation, the vast majority of those, there's a predominance of biological males identifying as female in the older cohort as opposed to the opposite in the younger cohort now that are coming forward in gender centers. There is longstanding data about healthcare outcomes. The best one that I presented last year was the Swedish population-based study. Lead author is Dane in that paper published in PLOS One, where it showed 20 to 30 years after receiving affirmative care that the rates of serious morbidity, including completed suicides, was markedly above the background population. So that data alone, and there's been more that's come out since that time, showing that the affirmation approach, contrary to the arguments that are being made in that older cohort, is not solving the problem. Now, the problem with those studies is they haven't been controlled. So you can't say what the affirmative approach did to that outcome, but you can say that it didn't fix the problem. So that there really are opportunities to engage more deeply in that. I also want to point out that that this heterogeneity that one sees in outcomes, in etiologies, can also be seen in outcomes as well. There's a very, very strong correlation that extends into adulthood for psychiatric comorbidities, most namely depression and anxiety, but eating disorders and these other things that we see are still in the adult population. So if you pull out an entire population, you're going to find some individuals that claim that they are doing perfectly fine. Okay, the data in adults shows, and there was a very good study that looked at this longitudinally, how long it took for an individual to come to the understanding that this transition was not helpful. And the average was about 8 to 10 years. And if you're doing a study that only covers 2 years at most, maybe 1 year, and some studies even 6 months, you're going to miss that cohort. The other problem with the adult literature in this area is that when you're trying to do those long-term follow-up studies, there's a tremendous attrition rate, meaning patients are lost to follow-up. In some of the studies, as many as 50% of the subjects couldn't be found. And we have no idea what happened to them, so we can't take any conclusions that they're doing well, at face value. Okay, we have to question what might have happened. So.
I've heard too that we're at a distinct disadvantage with regard to long-term follow-up here in the United States compared to other countries like Scandinavia and the UK, where they have socialized medicine and people are. You can query the database.
Well, I think, yeah, so that's why I looked at that population-based sample, because it doesn't have all of the sampling biases that are present in many of the other studies that were done, because they capture every single individual in that country. And even with that, prior to the explosion happening now in adolescence, the numbers were fairly low. So they had to get a whole population sample to have enough numbers to be able to do the analyses with any statistical rigor. I think, but the conclusions I think were very, very solid. That these individuals are not, or they're still suffering in many respects on an average basis.
Yeah, this question is you just partially answered it, but it's asking about other retrospective studies asking transgender adults and those that detransition regarding the perception of the physical and mental health. I'm thinking, you talked about the mental health, I'm also thinking about the physical health,
yes,
especially with regard to children.
Yes. Well, let me give you one figure. I might have said this previously to this group in the area of fertility. Okay, so if you ask even the people are now recognizing the risks of fertility in treating children, where the arrest pubertal development, so you don't get gonadal maturation, and then you expose them to cross-sex hormones. The expected effect is going to be infertility. That's irreversible. So if you query the children before they invoke on this regimen, about less than 5% have any concern at all about future fertility. When you survey adults that have undergone this intervention, about half wish they were able to have biological children. So there's a disconnect there. So there's effects on fertility. There are growing understandings not only in fertility, but even sexual functioning, arousal, and having the normal sexual interactions. Many of them end up having no partner at all. And not being able to function sexually. Some of the risks, bone density, really are only going to be manifested later in life when they're at risk for osteoporosis. outcomes like cancer risk and cardiovascular disease, as time goes on, the data is pretty solid as far as, but it's conflicting. So that all of the studies will they show an association. Okay, I think you can't make a causal inference by the quality of the data that one has, that they are increasing their risk of all these other morbidities. There's disagreement about the magnitude of that and whether it exceeds that of taking on a male taking on a female risk or a female taking on a male risk. Much of the data is actually showing a much higher risk. This is actually well recognized. What is often missed is that those risks are minimized in relation to suicidality and accepting that risk, knowing that or making the claim that if one doesn't receive this affirmative approach, it doesn't matter if you're going to have a double the risk of heart attack or a fivefold increase of thromboembolic stroke, because it's presumed you're going to commit suicide. Let me say a little bit more about that data. Okay, so first off, the suicide data correlates more strongly with the psychiatric comorbidities than it does with gender dysphoria. In fact, the actual suicide rates are on par for people that don't have gender dysphoria at all, but have major depression, okay, or substance abuse. So I think it correlates more with that. You can argue that, I think fairly strongly, that whether that's antecedent or consequent to that, that by addressing those other issues is of paramount importance, not the gender dysphoria, but the underlying depression, anxiety, and other things going on, risk-taking behaviors that people engage in. And then when you look at the data that says that the suicide rate actually it persists in that population after the affirmation, I think it leads to many concerns.
Next question. I've heard of Child Protective Services getting involved when parents do not accept their child's gender dysphoria.
Mm-hmm.
Do you think the general public healthcare providers will also be in trouble losing jobs soon as well?
So, the question, there's been real cases where children have been removed from the home because the parents don't accept, what is going on by these various centers. It's hard to know where we're going to go because the battle is raging on as we speak, and it's moving in both directions. So what's happening, and I didn't say this in all the detail that I could, when I talk about these laws that are being passed in these various states, almost all of them are being challenged. They're going to appellate courts. The circuit courts are often overturning so in many of the states that passed bans on affirmative care, the initial injunction was granted, preventing the law from going into effect. The circuit courts have overturned that. In many of these states, they've allowed the laws to go into effect. It's going to make its way up to the Supreme Court. So, and that goes in all of the areas, even probably the conversion ban laws. So I think that it's an unsettled or an unanswered question right now as far as what real risk a healthcare practitioner is going to face. Probably more likely than in the area of, in subtle ways, at whatever institution you work for and how much they require one, to adopt the model versus giving freedom, of being able to not engage. I find it in my own world that I'm addressing this as a major unsettled scientific question and encouraging scientific dialogue. And again, if one is using the Socratic method of challenging some of the things that are being made, that can be used, I think, in a way to be able to insulate and allow that dialogue as best as possible to be done without, I wouldn't say without any risk, but I would think with minimizing the risk for consequences in your ability to practice.
Question, is there a bigger problem in young women and girls versus males with gender dysphoria?
Yeah, I think I touched on a little bit of the demographics in that. Again, the largest growing segment coming to adolescent gender centers is going to be a female, biological female identifying as male. And there are many hypotheses that have been put forward as to why that is. historically, it had affected primarily biological males. I also didn't say that many of the historical cohort of the biological males presenting as females that undergo spontaneous realignment or desistance, there's a high number of individuals that have same-sex attraction. So going in, so there's lots of theories as why that is. For the females, there are some models out there and some hypotheses related to the challenges in adolescent identity development that occur in all children at that age, and the way that the gender question is relating to body image. There's also been documented cases of individuals, females, not being gender dysphoric, but their discomfort with menstruating, for example, or their fear of being physically abused related to some of the factors that led them to being labeled as gender dysphoric. So I think it's not a very simple answer as far as what's going on, but I think there are clear differences between males and females. There's also the population I didn't talk about this evening, but I did last year, about autism, the co-occurrence of autism and gender dysphoria, and we know that it's more often diagnosed in males than it is in females. It doesn't necessarily mean that it doesn't occur, more frequently and undiagnosed. So there are many different factors that might be going on, and that's why it's very important when we look at the literature, we look at weighing risks and benefits, that we're acknowledging these differences in the patient populations.
Are you familiar with the latest Netherlands 11-year study showing more than 85% of youth work through their gender confusion?
There's been a number of studies that have shown, and again, the difficulty now is that with the prevalence of the affirmation model and the social transitioning that occurs at younger and younger ages, to be able to replicate some of the earlier studies. The studies that I'm familiar with prior to adoption of the affirmation model universally is that there's a very high amount of what we call desistance or realignment of gender identity with sex. In the few studies that have been done looking at with social affirmation, the numbers are reversed. So rather than having about 85% have desistance, about 85% have persistence if you socially affirm somebody. Once you put them on a puberty blocker, it's closer to 100%. It's about 98 to 100% as far as going on to cross-sex hormones if you administer pubertal blockade. Now, of that number that go further and further down that pathway, it's not clear at what point in time or the magnitude of this later desistance is going to occur, but we know that the numbers are underrepresented in the published literature right now. The number that people give now is 1% to 2% at most, and it relates to the way the studies are done and the lack of individuals coming forward when they have this experience. There's a good paper that was examining the various reasons why or what led to an individual coming to that understanding and having that realignment of the gender identity with sex. And it's very informative to understand what is going on in the individual themselves, what is being assumed by the investigator or the practitioner as far as what's going on, and more importantly, what is being missed entirely by not even looking at it. So that there's a lot of confusion in the literature. So yes, there are studies from the Netherlands that, I mean, the latest ones actually show that the affirmative model, and that's what was cited in the CAS report as well, that social affirmation is not a neutral intervention. Okay, it's not just buying more time and letting them figure it out. It's actually more likely to be pushing them down that pathway.
It's interesting because that's very discouraging to hear what a number of us, of members of the Guild, went to testify in Wauwatosa a couple of years ago. There was their school district was enacting a new human growth and development program. And the good thing was that the people who were on the committee, they put it all out there. You could see all of the curriculum and lessons and how it was being done, starting in first grade and on, where confusion is just being sown. And as I say, it's very discouraging to hear that the schools are, if not cooperating, perhaps even encouraging this social transition?
Yeah, I think that there's the data, again, in this whole area, the way those studies are done have limitations and weaknesses, okay? So we can't be too definitive in drawing a causal conclusion, but it's pretty strong that the association is there, and it wouldn't be, yeah, I think you could say that that there are reasons for being concerned that what is being introduced in school-age children is having an influence on what actually happens in their identity development.
There are a couple of questions that deal with what we were talking before about sort of discussions with philosophy on philosophy versus science. What do you think of the latest Vatican document on human dignity regarding gender theory and sex transitions? Does gender theory make any logical sense? Many genders, how do you change bodies for many genders?
Yeah, maybe I can comment. So again, I speak usually in matters of science and medical practice, but there is a relationship between what we know from other areas, including theology, and this is probably very evident in how much they're speaking from different disciplines and really contributing in a very meaningful way. Having read the document on dignity, it is very, very well done and I think very clear. I think the clarity that needs to be done in this area of drawing concerns with the gender ideology, I think the church has actually stated very clearly in. Where the church has struggled is to put together that scientific understanding to be able to articulate, because that's not their domain, right? That's why it takes us in the medical profession to be able to provide that scientific and medical perspective to complement what we know from the anthropologic side of the discussion. And everything that I've read so far, there is nothing that I've encountered that has been in contradiction. In fact, there's a very much a harmony between what the two different domains, disciplines are contributing to the conversation. I do think that the theological perspective and understanding human anthropology is the basis for the contrasting premises, and the science, if it's speaking truth, will bear that out. So when one does the proper scientific studies based upon the proper or the valid premise, the result is likely to occur. This
was pointing out a number of other resources that are very helpful. CMA has a document, Ideology of Gender Harms Children. USCCB, Doctrinal Note on the Moral Limits to Technological Manipulation of the Human Body, deals with the underlying philosophy of medicine and the human person. And actually, in our own diocese, we have a wonderful document from. Have you seen that from the?
Yeah. So there's been a number of bishops that have put forward a number of different documents, and they vary. They're all saying the same thing. Some are saying it with nuance, and some are saying it without nuance. Being very, very strong. I think, again, initially, it's been very challenging, so that there's an element, what I'll say is, there's the medical approach, what is in the best interest of medicine, and then we know about the science of medicine, right? But we also know about the art of medicine. The corollary in the church is doctrinal theology and pastoral care. And this is where I think it gets confused with Pope Francis, where it's misunderstood, of focusing on a pastoral response, but being very firm in the doctrinal matter that's at hand. Now, I'm not a theologian. I'm not going to go any further than that, okay? But I leave it to those that are experts in that area. But I would say that when one looks at what we know from science, and when we look at what is being put forward by the different conferences, the USCCB, the NCBC, the CDF, and various bishops, I think what I've seen is pretty much a consistent, clear understanding of from an anthropological standpoint.
Can you give some examples of questions that you can ask a colleague or a patient who presents to you, and they're coming from the affirmative perspective? See Socratic questions that you
Yes.
could ask.
Yeah, that I could probably give you about 3 hours if you got it. But because I've actually had these dialogues with some of my colleagues that are engaging in the affirmative model, okay? So, I think just beginning, to understand. So the best thing to do is to say, to have somebody that you're dialoguing with, ask them to present the basis for what they're recommending. Okay, and if they say because WPATH says, say I won't accept that, I need to dig a little bit deeper. Have you read what they said? Do you know what studies were done? So some of the questions could be, what do you, how was those guidelines developed? What evidence was there? And then if you're familiar at all with the literature, you can ask them about specific studies that may contradict, what they might say. There's many inconsistencies, when they're making claims as well, that it's not to trap people, but it's to help them think about their assumptions, okay? So that one of the things that is often said is that sex occurs along a continuum. So you can have a whole dialogue about what sex is, okay? And just ask, from a biological standpoint, what is the purpose? And, how many gonads are there that participate in reproduction, and that sounds pretty binary to me. And what's the fertility rate in people that have disorders of sexual development? It's usually absent, right? And you can go through all of that. And then you say, well, that does it run along a continuum? Then I'm a little confused because this affirmative model sounds like a binary transition, right? So you ask that question, get them to think about, what they're advocating for. They often will claim that gender identity is innate and immutable, but then in the same sentence or the next sentence they'll say that it's fluid and it can change over time. And you can ask a question, how can it be both? It's either or, right? Those aren't necessarily, if you phrase them the right way, they're not threatening questions. They're just inquiring questions. I'm a little confused. How can this be? Are you aware? And allow them. I think it's always better to, again, listen. You ask the question and let them go as far as they will go, because many times what happens in the answer, and this has happened to myself as well, when I've had a position that I haven't had well supported, that as I'm talking, I start to recognize the inconsistencies myself. I'm not having the other person tell it to me. I'm starting to say, wait a minute, that doesn't seem right. Let me rephrase that. Well, that doesn't seem right. It's like, and then if you're successful, then the dialogue goes both ways, and they start asking you questions, and the same process will go on with you as well, and that'll be a fruitful conversation. I could go into much more detail. I can give you a couple of examples where I've done this, where the attitude was, I'm not looking at dialogue, I want you to accept my conclusion, and when the questions get uncomfortable and I know where they're going, I'm not going to answer any further. Okay, every dialogue, every conversation you have is not going to necessarily get to that end. But it's the process of planting seeds, okay? It's helping somebody. It's very hard when you're entrenched in a position, and this is for all of us, okay? We have to be fair about it. We all have biases, and we all come at it, and we don't very readily give up things that we claim to be true, okay? And how does one become stronger in their faith, right? When somebody challenges them in their faith. That's how I've grown. Okay, so I think there's a process that can actually be beneficial, and there's nothing to be threatened in doing that. So if you enter into that dialogue with that understanding, even if the person you're conversing with doesn't get there, you will be enriched in the process. And too often we're afraid to enter into the dialogue. We're afraid we're going to make mistakes. It's okay to make a mistake. Okay, it's okay, to ask the right. I mean, I've learned more from my mistakes. Of the way I can tell you all the ways that in those slides about how to act, and all the ways I've done it wrong. When I was equipped with this mountain of information, the first time I had an opportunity, I was like, well, how could you possibly recommend this study, this study? They didn't hear a word. They weren't ready to hear about science. What they wanted to know was that I cared about them as a human being, and that I wanted to listen to their story. Okay, and that was born out of mistakes. So I think that's how I would encourage you, to think about that. And it's going to be different for all of us. Okay, we're all coming at it from different perspectives. We have the questions that you're going to ask are going to be very different than the ones that I would ask. But just be willing, to offer that to people that may disagree with you.
And what I heard you say when you're confronting a patient is start by saying, tell me your story. I know that there was another related question.
Well, while you're doing that, so I want to add one more part to that as well. So they all want to tell their story. The other thing that I find when I encounter individuals that have this experience is not only do they want to tell their story, their entire life is told through that story, right? And one of the things that you can do you don't even have to have as a goal, to make any influence in what's going on, is to help them to see that their life is much bigger than that. And so you say, well, thank you very much. What do you do on the weekends? What are your hobbies? What are your talents? What do you like to do? That's not related to gender, and I think it helps people step out of that because they often are very hyper focused on that area as well. So you can begin there because they will tell you their story and they'll want to tell it to you. And I would encourage, after they tell you their story, it's not at a point about a rebuttal or a retelling of that story. It's their story, right? It's their own personal experience, and your goal is not to convince them of anything. It's just to enter into that dialogue, but you can also help them in the process of kind of opening up their vision from the laser focus on the gender issues, which often become all-consuming.
And I think the related question was, would you, when you're discussing it with a child, a person, would you bring up fertility issues? It sounded like, from what you said earlier, that that's not even on their radars.
Yeah, so I think independent of gender dysphoria, I don't know very many adolescents that are necessarily thinking seriously about those questions at that time of their life. So we have to have some understanding. I have the benefit of being a pediatrician as well, board certified in pediatrics, and so but I could extend this to anybody that's a parent, right? That you can understand a little bit about what's going on in that adolescent's life. I always say this in my diabetes clinic, right? And I'm trying to convince them that good blood sugar control is going to protect them from cardiovascular disease and renal failure and blindness, right? And that's going to happen years in the future. They're thinking about what's going to happen this weekend if you're lucky, right? It's a disconnect. So we have to understand where they're at developmentally, and it's not the most effective argument. Now I won't say anymore. I'll leave it at that.
Will those who transition have to rely on drug therapy medication for the rest of their life?
So the question is stated, those who, it depends on how far along the affirmative model they go. And I think, again, there's good reason to believe that if you arrest the development of an immature gonad and expose it to cross-sex hormones, that there are going to be fertility issues that are going to be long-standing. Many of the interventions, certainly with the surgery, are going to make you have permanent hypogonadotropic hypogonadism. So you're not going to be able to have the normal sex steroids of either sex, and are going to be dependent on the medical establishment for the rest of their life. And they'll need monitoring, for many of the complications. So you are depending on how far you go, many of them will be medicalized for life. And that's one of the concerns I have about some of the literature where people are in that situation where they've been medicalized to the point where they're dependent on the medical establishment, and then they're lost to follow-up. Okay, so then you have to question what is the basis for which they're not coming back to see you, and not make an assumption that everything is going well. Okay, so.
But those who do completely transition, they're on medicine for the rest of their life.
If you've destroyed their gonads, then that you're going to have to. They're just as similar to people that were born without gonads or functioning gonads. Absolutely, and the list is quite extensive as far as the risks that need to be monitored over time and being dealt with.
Could having gender dysphoria impact what sacraments you could receive in the church?
I'm going to defer that question because I'm a scientist and not a theologian. My understanding is, well, from what I've heard said, and I won't say any more than that, is that probably not, with the exception of maybe matrimony, because I know there's an impediment to the sacrament. Not infertility is actually not an impediment, but inability to participate in the sexual act is. So if you've rendered yourself incapable of doing that, that probably would make that not able to receive that sacrament.
There's a couple of questions that relate to kind of the same thing. What's been the reaction to new systematic reviews, the CAST review in U.S. academic medical centers? Are you sensing any movement toward the European restrictions? And so I guess an ancillary question is, how able are those who take your view to publish in our scientific journals?
Well, my own experience has been you can get anything published. It's just a matter of which journal you're going to get it published in and what the rigor is of the scientific review. And there have been many instances where people have been prevented, from getting their work published. It should be, the same standard. It has to be quality work, and so but as far as how the response is, it's too new right now to know fully. But what's happened up to this point in time, that as the several European countries, so Finland, Sweden, the UK, Norway, there's been some move to a lesser extent in France, in New Zealand, where they're moving away from the affirmative model. In some of those Scandinavian countries, in the UK, they've clearly stated that the prioritization is psychological care and are relegating the other interventions to experimental studies. The United States has dug in their heels. They've first tried to ignore that data, and they're continuing. The example of the AAP systematic review that is supposedly going on is an initial response to that. The data, systematic review. So I actually have helped to participate in some of the Cochrane reviews as well, right? So if you do a Cochrane review or any systematic review in a rigorous manner, it doesn't matter what you go into it wanting to see. If you do it rigorously, you're going to come to the same conclusions. And many times the best systematic reviews establish the study methodology before they even look at the data. Okay, so you examine what are the criteria you're going to use to look at the data for inclusion, exclusion, and how are you going to analyze the data. And then you look at the data, and if you do that rigorously, it doesn't matter who does the study, the results are going to be the same. I have my serious reservations and doubts about the way that the AEP, if they ever do a systematic review, how it's been done, but it should be brought to scrutiny as to how their methodology was developed. It's interesting that now the United States, so this was all pioneered in the Scandinavian countries. The Dutch model is often called for the treating kids with puberty blockers. Now the United States is viewed by much of the international community as the outlier. And it's not even called the Dutch model, it's called the American model, because what happened was in the original Dutch study, they were very careful to not include individuals that had underlying psychiatric morbidity. So you couldn't even be enrolled in the study. It was a very small study, and they realized that many of the methodological flaws in the way that the outcome data was reported. But most of the patients that are being enrolled in gender centers in the United States would not have been eligible to be even in the Dutch study because of the underlying psychiatric morbidity. So that's why people are calling it now the American model. And it's going to face increased scrutiny over time. And you can only stand on the hill of eminence for so long, okay? And I think the evidence is going to become more and more apparent. Now I have to be fair about this, okay? So when the proper high quality studies are done, if they're done right, one has to be able to, in an unbiased manner, look at the results. Okay, so we can't say that even from the side that we're going to show harm is a foregone conclusion. The studies just haven't been done the proper way. there's a lot of, when I write grant proposals, to the NIH, they always like to look for evidence even before the definitive study is done as to the rationale for proposing the hypothesis and why am I designing the study in the way that I am. And there's a lot of evidence that suggests, that they're much to be concerned about, but we need to be very rigorous about it when we do get to the point of higher level evidence. And again, randomized controlled trials can be ethically done, even though it's often said that they can't be done in this domain, if they're conceived and run in the proper way. But you can also have high quality longitudinal studies that can give you better evidence than we have currently as well. So there's many ways that we can address this. So I'll leave it at that.
The last question, and maybe we'll have a couple more minutes, is dealing with the legal side of things. And actually, we have Attorney Andrew Bass here from Thomas More Society. How that all is going to play out. This question says, can you comment on the congressional investigation of the Gender Center at WashU, especially Senator Haley questioning?
Yeah, so I'm not going to comment about anything at Washington University because I don't know, and probably wise not to. But I will say more generally that there, in some of the litigation that's going on, there is it's coming into the forefront. Some of the things that are in the WPATH files, there's likely to be much more and much more solid evidence that's going to be coming out as members of these organizations are being called to testify under oath with threat of perjury, to be able to describe, what was going on in the processes. There's efforts to get the AAP to state how their policy was developed, who was involved in selecting members, for the various policy statements, those types of things. So that'll come out over time. I've been working as an expert witness in cases, related to this long enough to realize that I'm not going to make any predictions, about where things are going to go. But I will say that in the process of litigation, there are already movements that are becoming very apparent. First off, many of these cases are going to make their way to the Supreme Court. I think almost everyone involved in that. There are questions that need to be answered at that highest level. That the influence of malpractice litigation cannot be underestimated. I think that if one is not going to acknowledge the scientific questions, the liability issues, the difficulty is in these cases is that, and again, it's not to apply it to every single individual, but the ones that are being vetted and coming forward right now, my understanding is that many of the ways that they were evaluated and treated by all objective criteria do not meet the bar of medical standards that are required. And so it'll be interesting to see how how they proceed through these different court cases, and it's already having an effect. What I would like to see happen, okay, is that the U.S. medical establishment takes a pause and says, let's look at the actual scientific evidence, and even from a posture of nobody likes to say we made a mistake, okay? But you can say, let's look at what the evidence is available now that I may not have been aware of earlier. Whether I'm liable for not knowing that or not is a different, I'm not going to argue that. But I think that will make a difference, okay? This still remains a very highly contested societal issue. That dialogue doesn't seem, the parties do not seem to be coming closer together. They're actually moving further and further apart. I don't expect that to change much in the near future, but I think that what is having an impact, even aside from malpractice litigation, is that the stories of individuals that detransition are very compelling. I think if any of you are going to be at the CMA meeting in Orlando, they are going to invite some people themselves who detransition to tell their story. And I know some of the stories, and they're very, very powerful.
I wonder if, Andy, I hope you don't mind my calling on you from the Thomas More Society. Are there Are you involved with any cases, say defending healthcare providers for being pushed to do certain things, or any cases that relate to this issue?
Well, the Luca Hun case that Dr. Hruz mentioned earlier is our case. We filed suit against the University of Nebraska Medical Center. That's basically a medical malpractice claim on behalf of detransitioner Luca Hun. We don't think we filed suit on behalf of a physician who was forced to use the preferred pronouns and provide treatment. We had filed a lawsuit on behalf of two teachers whose school policy was very common, required them to use the preferred pronouns and treat the children the way they wanted to be treated and not tell the parents, and even if they're asked a direct question by the parents. And we've gotten injunctions for them. I imagine we could do it for healthcare providers too. We've represented many health providers who object to becoming vaccinated because of the abortion connection. They have religious objections. We've gotten a lot of them religious accommodations and filed suit and still have suits pending on behalf of others under Title VII.
Very good. Any other, since we're finished with the written questions, we can maybe take another question or two.
I think you talked about this last year, Dr. Hruz, but I'm being a psychiatrist. I mean, the quality of the psychiatric evaluations. I mean, is that even being when they eventually look at the data in the United States? My guess is that they're of very poor quality or varying quality. I mean, anyway, can you just comment on that?
Yeah, so the question of the quality of the psychological investigation in these individuals that are coming, to gender centers, there's a history, to that, and it's in stark contrast to the holistic model that's being proposed in the UK right now. So not only, is it not being done, it's actually discouraged from exploring deeply into some of these underlying psychiatric or psychological events that happen early in a child's life, being viewed that would be a barrier to receiving care, or being perceived as being akin to conversion therapy, which now certainly the best person to answer that is my colleague Laura Haynes, that I know, who has done extensive research into this particular area. So in most areas of, and I'm again an endocrinologist, not a psychiatrist or a psychologist, but to ask basic questions that might probe things that might be contributing to the presentation with depression or anxiety is considered standard medical practice, right? And so the directive saying that that's a barrier to getting the affirmative care that one seeks coming to the provider bypasses that even an attempt to do that. So either there's a directive that it's harmful, or there's a fear in the provider that by asking those questions they're going to be accused of engaging in conversion therapy, or that that if you come to a conclusion that maybe we need to address the psychiatric issues before we go forward with this, and the patient's consumer-driven medicine, I want this now, and you're not helping me, then there's a lot of legitimate fear in being able to do that. And I know many of those that I've spoken with in that profession have expressed all of those concerns and reservations, and are troubled by that.
Because it's just so counter to us, like as physicians, the algorithms we go through are to first treat the easy things. I mean, diagnose and treat the easy things.
Right.
And then go from there. And my guess, I mean, I have nothing to base this on, but my guess is that so many of these people, if they were treated properly for their anxiety disorders and major depressive episodes,
Right.
I'd love to see that data, if, once they're treated.
Yeah, and I think many have argued exactly as you said, that even if we don't have a goal of influencing the gender dysphoria, it's good medicine to use methodologies that we know are effective, and help them.
Mostly harmless.
Yeah. So, if you actually look at the data of the affirmation model in the psychiatric care, there's been some very good studies that over time, medication use doesn't go down. psychiatric needs don't go down. In fact, there's some evidence that it might actually increase over the duration that they're being cared for. So it supports your contention. So.
You have resources for, I'm in family practice, and so I'm thinking of in my practice, I have people that are now followed by a clinic where they've had a surgery for their own medicine. And I tell you, I see them, and I might see them. They don't usually come in for physicals anymore, and I'll see them for maybe their anxiety disorder, and I'm wondering about how I should be following them for the fact that they're on high doses of testosterone,
Mm-hmm.
and I'm just kind of like, this is above my head, and I just, honestly, sometimes I'm so focused on just some of the anxiety that I'm fearful that that's not being looked at. Because I asked them once about it to get levels drawn, and they kind of just looked at me, and I can't find anything in Epic
Yeah.
about it. I don't know if it's protected information, but
Yeah.
I'm not seeing levels, I'm not seeing, and I just wonder
Mm-hmm.
if there's resources for someone like us that may not be the primary thing, but now we have to think about it.
Yeah, so what you will find are the ranges, if you want to look at sex steroid hormone levels that are intended to be achieved in the affirmation model, and whether they're in range or not. There's an interesting conversation about which reference ranges one should use. So you can certainly determine whether the levels far exceed even those ranges. But even a female having a testosterone level in the male range is still very much elevated above the normal female range, and knowing the genetic differences and disease susceptibility and effects of that are very concerning. The answer is there's not clear data. Okay, so of the effects, we do know that the sex steroid hormones do have very important and significant effects on mood. And that the abrupt change in those sex steroid hormone levels are likely to have very significant effects on mood as well. And that's why there is some cautions about going cold turkey off of them if one desists. And there's no science to look at what the best approach is going to be. There's none. And there's a lot of discussion about even making recommendations in the tentative recommendations in the absence of any evidence, and then trying to find the right data. There's a lot of claims that are made that are based on no science, and to say that giving estrogen to a female is the same as giving it to a male is based on a faulty premise, and we already know from other situations where that statement is contradicted and not true. So for somebody in the trenches, so this is very difficult, and I encounter this as well, that somebody that's already in the affirmation model, right? They're coming in to see you for a different purpose. To what extent are you going to be able to impact, what's going on? And I think many have chosen the path of putting the blinders on and saying, okay, what is the problem? Let's address the problem here, and then maybe make a suggestion in some way about what type of care might be added to what's going on right now. Most of the time, the other point you mentioned is that you rarely see them, and there's great data suggesting that many of them don't come in for regular screening tests. They're fearful that they will be rejected by their healthcare providers, and they only come in an emergency model. And I think there's an opportunity there on the positive side, and I think this is where we need to this is the engagement of not being necessarily judgmental to them, and being able to open up and being as open and caring and loving as you can, as you would in any other situation. That there's a perception that's often not the truth. So the provider wants to do everything they can. The person already has made the conclusion that you're not going to accept them for them, or you're going to, and their biggest fear is that you're going to, in the clinic visit where they come in for their UTI, is you're going to try to get them off of their hormones. And that's why they won't come in to see you, okay? So that you can argue, and again, I can't answer the question for you because it's a very complicated question, depending on your relationship with the patient, your likelihood of future relationship, and what your sphere of influence is going to be. I think it's probably, if it's somebody you haven't seen before, The first goal is to address the immediate problem, and the second goal is to establish that doctor-patient relationship so that they'll be able to get their other primary care, and in the process of developing that relationship, dialoguing in these areas. I think that's about, for a primary care provider, that's probably realistic and probably the best goals, advice that I could give.
One more question and then.
Yeah.
I guess I would like to address what he said, because when I was in practice, I had several transgender patients too. And, they're desperate for a relationship. I had one guy, one transgender patient drove 50 miles one way to see me because I was the only person who would sit down and talk and build that relationship. And when, complications occurred and we needed to adjust, get that person off their hormones, they were willing to listen to me, and we did it because we had to do it. And so I think, just knowing, not that you accept what they've done, but you accept that, that they're more than that. And it's amazing how far you can go when you do that. But, but my concern is that, now that people, even within the field are starting to recognize the paucity of the data, they're just going to move the end zone, because they'll say, okay, then we won't do this treatment because we can't whatever, but we still think that people can change their genders, and we still think that, which undermines some of the philosophy of, what is the essence of medicine, and what is our roles as physicians? Are they to help people accept their reality, or are we to, let them be whatever they want to be, even if it's not real? And which is why I like the USCCB paper so much, because it goes a lot more into that, because so much of what I read that's coming out of our organizations, and one reason why, I did a lot of helped with the CMA paper, is that we talk about, oh, well, this is harmful, this is bad, this is, we don't have this data, we don't have the science, we don't have this. But as things change, there still has to be an underlying value that we have to affirm ourselves, because no matter what happens out here, as the facts, as the treatments change or whatever change, there's still an underlying reality, of our body-soul union, of who we are as persons, of our understanding of ourselves as persons. And if we don't have that basis, they'll just keep changing the end zone, and we're just going to keep playing catch-up.
Well, thank you for sharing. I think the perspective that it's a different perspective, and it's good that I have, because I've not had the in-depth experience that you've had in that area. So thank you. We have to be adamant about this question of equipoise. We don't know for sure what the best treatment is, and demanding that alternative hypotheses be entertained. That's the way I would do this in a scientific way, which states a different premise, right? And so that we can say scientifically that that's the premise, and therefore, based on that premise, then the alternative approach of addressing psychological health as a primary intervention not only makes sense scientifically, it's in harmony with that anthropologic understanding as well. So,
Well, thank you so much,
Yeah.
Paul. I think your experience has been so valuable, and also I think just being able to, how do we navigate through this? I think a lot of your recommendations are really, really helpful to engage with the person and not come with guns blazing and so forth. So I think that's very helpful, and I thank you again so much for coming back.
my pleasure. Thank you for inviting me. Thank you.